another episode of this going to be Pulmonary and Critical Care ABIM board review using MANUS AI on our channel. If you're not familiar, what we do is we create board questions using AI, and especially common educational objectives that are tested on the internal medicine boards. And we go through the 5-step method to break down the question and understand the pathophysiology, and also just focus on high-yield things that you need to know to ace the boards. And these could be numbers that you really have to memorize, and there's no other way around it other than memorizing these numbers, or specific indications, contraindications that we do here. The questions don't have any distractors. They're focusing on specific objectives. When you see the board questions, you're going to be able to quickly realize what objective they're asking for, and you'll be able to hone in on the correct answer. And the goal of these episodes is for you to basically be able to remember the educational objectives and get rid of the distractors and pick the right answer based on the correct indication, communication, and knowledge or skills that you need to have to be able to answer it. All right, so let's go ahead and get started. Without further ado, the first question. This is a 72-year-old man with a 40-pack hair smoking history. He presents to your clinic with worsening shortness of breath. He reports being unable to walk across his living room without stopping to catch his breath. His medical records show his FEV1 is 25% predicted, and he has been hospitalized 3 times in the past 6 months for COPD exacerbation. The current vital signs show oxygen sat of 86% on room air, respiratory rate of 24, heart rate 105, ABG shows a PaO2 of 52 and a PaCO2 of 54. The patient has lost 12% of his body weight in the past 5 months. Which of the following is the most appropriate next step in the management of this patient? So go ahead and pause the video right here, pick your answer. We're going to go through the options together. All right. So this is of course, you've realized this is a very, very severe COPD, and they're going to see if you know what to do when a patient has severe COPD to this extent, right? So, of course, the answer is to request for hospice, but there's indications. So we're going to go over this. This is the pathophysiology of disease. It's going to tell you that COPD, is characterized by progressive airflow limitation. It could be due to an abnormal inflammatory response to noxious particles or gases, primarily cigarette smoking. In end-stage COPD, several pathophysiological changes happen, which are very important to know. There's airway remodeling, which means that the inflammation that's been chronic leads to fibrosis and a lot of mucus production and destruction of the bronchiolar attachments. There will be severe emphysematous changes. You see those on the chest x-ray when you review, because the alveolar walls are basically destructed and destroyed, and there's less surface for gas exchange. Pulmonary vascular changes can happen. There will be hypoxic vasoconstriction and vascular remodeling leading to pulmonary hypertension. There's going to be respiratory muscle dysfunction where the diaphragm is hyperinflated, and systemic inflammation is going to happen, leading to cachexia and extrapulmonary manifestations. So in this patient, you have severe airflow limitation. FE1 is 25%, and he has severe hypoxemia with a PaF of 52 and hypercapnia with a PaCO2 of 54. The respiratory failure combined with this increased work of breathing has likely contributed to his tachycardia and weight loss and this catabolic state and very poor prognosis. So the key clues here were that this is very disabling, right? The FEV1 is well below the 30% threshold. There is frequent hospitalization. There's hypoxemia. There's hypercapnia. There is also changes in vital signs and weight loss. So the first one, the option, was saying initiate long-term oxygen therapy and pulmonary rehab. these, while oxygen therapy is indicated for hypoxemia, the patient's multiple criteria for hospice eligibility. Pulmonary rehab, though beneficial in early stages, would be too burdensome given this amount of functional limitation. Referring for long transplant evaluation, this patient is 72 years old and has multiple end-stage manifestations, will be basically not a good candidate for transplant. Starting the triple therapy is appropriate for symptom management, again, but insufficient as the primary intervention given this presentation. Recommending non-invasive positive pressure ventilation. While NIV can be used for hypercapnic respiratory failure, it is primarily indicated for acute exacerbations or specific and chronic situation, not primary management. So this is very important to realize at this stage. Hospice would be the best for this patient to make him comfortable. Now let's go through the algorithm. So whenever you see a question on COPD, first you need to always decide how severe this disease is. And what you need to know, the magic number, is the FEV1 less than 30%. This should ring some bells in your head, thinking about the COPD being very severe. Then see also how many times, how functionally declined is this patient is. What can they do? What are the ADLs? Evaluate for disease progression. Is she getting worse? Is there more hospitalizations this year, despite all this optimal therapy that they're on? Then check for respiratory failure. What is the PaO2? Is it less than 55 with the O2 side of less than 88%? And is there hypercapnia? What's the PaCO2? Is it greater than 50? And look for additional, poor prognostic indicators, which in this patient are the tachycardia, the weight loss, cor pulmonale, the right heart failure, which wasn't really mentioned here, but you need to always have as a part of the pathophysiology of chronic lung disease in your tool set, because it's very important to know that what is the severities and through time, which levels of this and how many organs or other organs get affected. That's why I'm saying about the pathophysiology. So decision point, if multiple criteria are present, consider this hospital referral. Now this kind of repeats itself there, but when we go through the latest American guidelines for hospice, this is important, right? So patients with COPD are eligible for the Medicare hospice benefit when they have, so this is directly from these guidelines, and will be tested, FEV1 less than 30%, disabling dyspnea at rest, progressive disease leading to end stage, severe hypoxemia this patient has, which you need to need these numbers, PaO2 less than 55 or O2 less than 88% on room, hypercapnia greater than 50, cor pulmonale or right heart failure secondary to pulmonary disease, unintentional weight loss greater than 10% over 6 months, and resting tachycardia. Always, one of the things that I always try to ask residents that I'm working with or medical students is, which kind of tachycardia would you be more worried about when you see in a patient? And everybody, if I give them options for AFib or other arrhythmias, not of course the VFib or the ones that you see in ACLS, but actually sinus tachycardia could be actually one of the worst kinds and worrisome kinds of arrhythmias, if you want to call it that. But in these patients also, that resting tachycardia is a very poor prognostic factor or indicator of poor prognosis, right? So very important to know these and for your boards, so you need to know these numbers, and the only way to really remember these numbers is do as many questions as possible or create memory cards and keep refreshing your memory so that you're able to directly go to the right option. Because from someone's perspective who doesn't know these numbers, right, if you were to just look at this question, it seems like, if you didn't know this is too low and all that, and then sometimes on boards they try to trick you, you'll be like, oh well, this looks right. Oh, maybe she will be, a candidate for lung transplant. Oh, why not try the pulmonary rehab? Like, everything sounds good, right? So if you don't know the severity, and don't know how to, when hospice becomes indicated. Okay, so that's the first question. I hope you guys are learning. If you're learning, don't forget to give a thumbs up, subscribe, leave a comment. Let me know what you like or you don't about these sessions. This is for you guys. The notes are always going to be posted on my Patreon channel if you would like to donate. If not, you can just watch the videos. And let's go ahead and get to the next question. All right. So this is a 68-year-old man. He's brought to emergency department after being found unresponsive at home. On arrival, he's pulseless with a cardiac monitor showing VFib. CPR is initiated immediately after 2 unsuccessful attempts at peripheral intravenous access. The physician considered alternatively routes for medication administration. The patient has a BM of 38 and has significant peripheral edema. Which of the following is the most appropriate next step for establishing this vascular access? Again, the reason this question came in this pulmonary episode, this is a pulmonary and critical care and ICU, and access is very important. We may not really deal with this as internal medicine physicians or residents, which is why I think it's good to review and go over guidelines, because everything should be done based on the guidelines of medicine when they're indicated. So go ahead and pause the video right here and pick your answer. We're going to go through the options together. All right. So I hope you realize that this question is asking about access, and they really want you to go for intraosseous access in that proximal tibia. Now let's talk about why this is important. So you have cardiac arrest, you have severe shock, and you have peripheral vasoconstriction as a compensatory method. You have venous collapse, right, because of hypovolemia. You have catecholamine surge, and you have tissue edema. Capillary leak in fluid resuscitation can cause significant tissue edema. So at the level of a vascular, you have a lot of issues that could make the vascular access difficult during severe shock and cardiac arrest. So very importantly, and very important to note, that the medullary sinuses of long bones are great for in these cases because they're not collapsible, right? So rigid bone, they have a lot of vascular tissue, right? They're very vascularized and direct connection to the central circulation. They are protected from external compression, right? So if the patient has, peripheral edema and external compression from any other reasons, these bony structures are way easier to access, and they're very rapidly accessible. 60 to 90 seconds, once you learn how to place one of these, you will see how easily they can be accessed. These are especially useful also in obese patients and the ones with severe peripheral edema, where you're trying to give medications and you have a very important timeline to act, and you don't really have time to keep trying getting a vascular access. They're even way faster than if you were trying to do a fem line, a central line on these patients. So very important. And so the key clues here were the patient, cardiac arrest and ongoing CPR, VFib, 2 failed peripheral attempts, very important, obese and peripheral edema. So I gave you all of the indications that maybe you need to get this different type of access. So discontinuing attempting the peripheral IV access would be wrong after 2 failed attempts. Performing endotracheal drug administration, again, it used to be used hysterically, but it is no longer actually recommended as a primary alternative route, because again, you don't know how much of this drug that you're giving is getting absorbed, right? And if it's getting to the right areas, and if the patient has lung injury or not, what's really happening. So not very the best method. Only certain rare cases where you have to, otherwise IO access is much better. Attempting central venous catheterization in the femoral vein, Not really bad. Again, if they're doing CPR though, and you need it right away, may not be the fastest way. And then establishing the access in the proximal tibia provides rapid, reliable access, central circulation, high success rate. You can do that while they're doing CPR. And just kind of algorithms. Initial assessment is the patient in cardiac arrest. Is this, when an urgent scenario? Did we try the peripheral and we couldn't get it? Maximum 2 attempts or 90 seconds. Where we, if we were unsuccessful or not. Decision point of alternative access. Is provider skilled in IO placement? Can they do that, especially like in the ED settings? Or their contraindication to IO access. This patient has, fracture, infection in the bone, or previously IO attempted in the target bone mentioned. IO access considerations. So select the appropriate site. Adult patient. Consider proximal tibia, humeral head, or distal tibia. Obesity present. Proximal tibia often preferred due to the reliable landmarks. And when those are contraindicated or fail, when the IOs fail or contraindicated, you can do the central venous access. And consider the ET administration only if no vascular access options available, and limited to only lipid soluble drugs. So this is the kind of the mnemonic naval that they use. So you can give naloxone, atropine, vasopressin, epinephrine, and lidocaine. Those are the only ones that you can give through the ET tube. But again, this is very last line. If all else really fails. And then this kind of goes over the same thing. And then let's go through the latest American guidelines. Again, intraosseous access is recommended as the first alternative to failed IV access. During cardiac arrest, IO access should be considered after no more than 2 failed IV attempts or 90 seconds of trying. All ACLS medication fluids can be administered via IO, and it's the same dose as IV. Proximal tibia, humeral head, and the distal tibia are preferred sites. IO access can deliver flow rates up to 125 under pressure, of course. And that's really good for you guys to know about. It's not something that we get commonly thought on as IM physicians, but very important skill to know about. Access. Establishing access is one of the most important situations, especially when you go to rapid responses. One of the things that I also teach medical students residents that they start in the hospital, is when you go in the room, of course, you go through your rapid response elements, but also one of the first questions that you ask is, what kind of access do we have? Because the access becomes very, very important. If you don't have access and you're running a code, and then in the middle of the code, you're like, oh, we don't have access. It'll be a mess. And you'll be, shocked that this happens in the hospital. Patients remove their lines, or the line infiltrates, or, there's so many things that can go wrong in the hospital, especially in very sick patients. So very important to always check. So let's go ahead and move to our last question. Again, if you're enjoying these questions, please leave a like, comment, subscribe. Let me know what you like or don't. This channel for you guys. If you want to download the notes on Patreon, you can donate to me on there. If not, anything, any comments or subscriptions and all of these will really help grow the channel, get it out to the community. We're changing the way we're studying. AI is getting integrated in everything. We need to get ahead of it, learn how to use it. And this channel is here to show you how important it is to use this as a tool to prepare. All right. So let's do this last question. This is a 28-year-old woman, presents to ED, complaint of dizziness, headache, shortness of breath that began 2 hours after applying a topical anesthetic cream for a planned tattoo removal. On examination, she appears cyanotic, and despite the oxygen stat of 85% on pulse ox. Her vital signs include blood pressure 118 over 72, heart rate 110, and respiration rate of 22. Temperature is 37. ABG shows a pH of 7.38, CO2 of 38, O2 of 98, and HCO3 of 22. The blood in the arterial sample appears chocolate brown in color and does not change with exposure to room air. Which of the following is the most appropriate next step in management? So if you know, you know. Go ahead, pause the video right here, pick your answer. We're going to go through this together. All right. So, of course, this question is testing you on methemoglobinemia. And I've had the luck to actually see a patient or two during my residency. And the patient was clearly cyanotic, but the context that that patient came in was not a topical antisynotic cream. It was actually the patient using the azo medication for UTI. The patient had chronic UTIs and was taking that medication over a long period of time, and that patient presented with methemoglobinemia. And one of the things that I noticed was that I did see the chocolate brown color. The respiratory therapist sent me a picture of it, which made me remember to this day. The most important things that you will see is the cyanosis and this difference in PaO2, which is 98%, but the pulse ox of 85%. So, very key to immediately recognize this and see if whether your patient needs is actually indicated to get the medication for treatment, which is the IV methylene blue. So, methemoglobinemia, remember that it occurs when iron in the hemoglobin is oxidized from Fe2 to Fe3 state. The pathophysiology change has several important consequences. You impair the oxygen binding, right? So the methemoglobin cannot bind oxygen. It reduces the oxygen carrying capacity of the blood. It also causes a left shift oxygen dissociation. That means that the remaining normal hemoglobin binds the oxygen more tightly, but releases it less rapidly. That means that you see that PaO2 on ABG is 98, but the patient is hypoxemic because he's not able to get the oxygen released to the tissues as the hemoglobin is not releasing that oxygen. Functional anemia, which means even with normal hemoglobins, oxygen delivery is compromised. Resistance to pulse oximetry. Standard pulse oximetry cannot distinguish between this methylhemoglobin and deoxyhemoglobin, typically reading around 85%. But on IBG, you can also get levels of each of the methemoglobin, deoxyhemoglobin, oxyhemoglobin, all of those. Carboxyhemoglobin, right? Methemoglobinemia can be congenital, which could be due to the cytochrome B5 reductase deficiency or hemoglobin M disease, or it could be acquired, caused by exposure to oxidizing agents. Very important, right? So Fe2 to Fe3. Local anesthetics such as benzocaine, lidocaine, prilocaine, antibiotics like dapsone, very commonly tested, sulfonamides, commonly tested, the nitrates and nitrites, the nitroglycerin and nitroprusside, commonly tested, chemicals such as aniline dyes and naphthalene. So this patient, was using a topical anesthetic cream, which likely had, benzocaine or lidocaine, and oxidized the hemoglobin to methemoglobin, caused the chocolate brown blood, and so. The key clues were the exposure, the cyanosis, the saturation gap, comparing the pulse ox to the ABG-O2, the color that you see of the blood, and the symptoms that were very consistent with this. And if you watch one of the recent episodes of, I think it was the Pit, there was a guy who came in and completely cyanotic, and he'd done something that they didn't really reveal what he did, but they did find that he had methemoglobinemia. That was a kind of interesting. I thought that when I watched the episode, I thought that the amount of skin cyanosis that guy had was very, very severe. I thought it may have been a little bit more dramatic than what I expected it, but I have not seen that severe of a methemoglobinemia before. So when you go through the options, right, the answers: administering high flow with non-rebreathable, it's not harmful. It won't be effective as a primary treatment. The issue is that the hemoglobin is not able to release the oxygen due to that altered state. Performing each endotracheal intubation, again, the patient doesn't have a problem with PaO2, right? So what is the point of intubating? Administration of intravenous sodium bicarb. Patient did not have any acidosis. The pH was 7.38. Doesn't make sense there. It doesn't really address the underlying cause. Ordering a CTA to rule out a pulmonary embolism. Again, while PE can cause hypoxemia, it would not explain that a normal PaO2 again. So it doesn't make sense. Always we need to make sure our diagnosis is right on point. Administering IV methylene blue. So this is the specific antidote that we use for symptomatic, okay, methemoglobinemia. Methylene blue acts as a cofactor for that NADPH methemoglobin reductase, which reduces that methemoglobin back to hemoglobin. It is indicated for symptomatic patients or those with methemoglobin level greater than 20%. This is also very important and need to know that this level greater than 20% could be tested on boards and may give you methemoglobinemia that's not as significant, and you will not be using that medication if the methemoglobin level is not greater than 20% or the patient is not symptomatic, right? So this is kind of going through the algorithm: cyanosis, saturation gap, chocolate blood, history of exposure to oxidizing agent, how severe is it symptomatic, do they have hemodynamic instability, is methemoglobin level available, can we get that on the ABG to see if the patient is clinically indicated for that methylene blue. Discontinue the offending agent, provide supportive care, administer supplemental oxygen, can be given, again, not really primary treatment. Decision point, symptomatic or, just remember that, symptomatic or methemoglobin greater than 20%. Okay, so very important. If yes, administer 1 to 2 mg per kg, IV over 5 minutes. If no, observe and provide supportive care. Contraindications to methylene blue, very important. They try to tell you the patient has a history of G6PD deficiency, presents with the symptoms of methemoglobinemia. If the patient has this, you cannot use methylene blue. If they tell you the patient is on serotonergic medications, there is a risk for serotonin syndrome. They do like to test you on these. They may tell you the patient is started or is on multiple antidepressants, and would you want to give this medication, right? So very important. And reassessment after treatment to see how they're doing, considering setting second dose if needed. The maximum is 7 mg per kg total. Alternative treatments, when the methylene blue is not indicated or is ineffective, you do exchange transfusion, hyperbaric oxygen therapy, or ascorbic acid. And I personally tried this before, giving the ascorbic acid. So let's go to the last step, which is the American guidelines for methemoglobinemia. Just goes again over this. For symptomatic methemoglobinemia or methemoglobin levels greater than 20%, recommended dose may repeat after 30 to 60 minutes. If the symptoms persist or methemoglobin levels remain elevated, maximum cumulative dosage is 7 mg per kg. Contraindications: remember, in G6PD deficiency, you cannot use methylene blue because it can lead to hemolysis. If the patient is on concurrent serotonergic medications, severe renal impairment is a relative contraindication, not definite. But if they give you this, they probably give you a severe renal problem or someone in CKD stage 4 if they were to make you not pick that answer. Immediate discontinuation, supplemental oxygen, co-oximetry for definitive diagnosis, and alternative treatments for refractory cases or when methylene blue is contraindicated. Also, yet you may get tested on exchange transfusion, hyperbaric oxygen therapy, or high dose ascorbic acid. Less likely this one. I think if that was the case, you would probably get tested on this part. For a patient in shock with extreme high methemoglobin greater than 50%, guidelines recommend considering blood transfusion or exchange transfusion in addition to that methylene blue therapy. So this is in case of a very, very severe, probably the guy completely cyanotic and the methemoglobin is greater than 50%. This is where you may need to probably do both, give blood transfusion, exchange transfusion, in addition to the methylene blue therapy. Okay. So This is it, guys, for this episode. I hope you guys enjoyed the episode. The goal of these episodes to break down questions, tackle every single important high yield point about a specific educational objective that's going to be tested on your internal medicine board exam. Some of these are definitely important for even medical students taking internal medicine shelf. The diagnostic parts can be tested there. Maybe not as the doses and how often you can give and things like that, but again, it could be appropriate for them as well. Or if you're trying to see if you want to be an internal medicine physician, these episodes, watching a few episodes, see if you really like to know all of the details about everything basically that comes into the hospital. As a hospitalist, if you decide to do hospitalist, which is my plan to do, you are the bridge to connect all different subspecialties of medicine, because you are the one to know who to consult and be able to connect, especially if you have a complex disease that is multi-system involvement. You need to know all of the systems to an optimal level to be able to coordinate care for a patient. I think it would be a good idea for us to do an episode on whether you should become a hospitalist or not. I am very passionate about hospitalist, and so I think that will be a separate episode. We'll have that in the future. If you guys enjoyed the episode, don't forget to do all those things. I'll see you on the next one.